Today we are going to talk about inflammatory bowel disease in dogs, more accurately discussed under the broader term chronic inflammatory enteropathy, or CIE. CIE is a syndrome of chronic gastrointestinal signs, usually lasting more than 3 weeks, after other causes like parasites, infection, endocrine disease, pancreatic disease, diet-responsive disease, and neoplasia have been considered. Common signs include chronic diarrhea, vomiting, weight loss, decreased appetite, flatulence, borborygmi, melena, hematochezia, or poor body condition. The pathogenesis is multifactorial. In a normal dog, the intestinal immune system tolerates food antigens and commensal bacteria. In IBD, genetic susceptibility, intestinal dysbiosis, impaired epithelial barrier function, and abnormal mucosal immune regulation cause an exaggerated immune response to luminal bacteria or dietary antigens. This leads to inflammatory cell infiltration in the lamina propria. The classic histologic pattern is lymphoplasmacytic enteritis, but eosinophilic, neutrophilic, granulomatous, or mixed inflammation can occur. Inflammation damages the mucosa, decreases nutrient absorption, increases intestinal permeability, and may cause intestinal protein loss. Severe cases can progress to protein-losing enteropathy, where albumin, globulins, and sometimes cholesterol drop because they are lost through the diseased intestine. Diagnostically, IBD is a diagnosis of exclusion, but the practical gold standard is intestinal biopsy with histopathology, obtained by endoscopy or surgical full-thickness biopsy. However, biopsy alone is not enough. The diagnosis also requires chronic signs, exclusion of other causes, and appropriate response to therapy. Minimum database includes CBC, chemistry, urinalysis, fecal flotation, Giardia testing when appropriate, and empiric deworming if parasites are possible. CBC may be normal, or show mild anemia, eosinophilia, neutrophilia, or lymphopenia. Chemistry may show hypoalbuminemia, often below about 2.5 grams per deciliter, and severe protein-losing enteropathy becomes more concerning when albumin is below 2.0 grams per deciliter. You may also see hypoglobulinemia, hypocholesterolemia, electrolyte abnormalities, or increased liver enzymes. Serum cobalamin and folate are important. A typical canine cobalamin reference interval is about 251 to 908 nanograms per liter, so values below this suggest hypocobalaminemia. Cobalamin is absorbed in the ileum, so low values can suggest distal small intestinal disease, EPI, or dysbiosis. Folate is usually around 7.7 to 24.4 micrograms per liter. Low folate can suggest proximal small intestinal disease, while high folate can suggest dysbiosis. Rule-outs are critical. TLI evaluates exocrine pancreatic insufficiency. Depending on the assay, canine TLI values less than or equal to about 5.5 micrograms per liter can support EPI. Spec CPL helps assess pancreatitis. Values 0 to 200 micrograms per liter are generally normal. 201 to 399 are equivocal, and 400 or higher supports pancreatitis. If Addison's disease is a concern, a baseline cortisol above 2 micrograms per deciliter makes hypoadrenocorticism unlikely, while low values require ACTH stimulation testing. Ultrasound may show intestinal wall thickening, altered layering, mucosal striations, enlarged mesenteric lymph nodes, or lymphangiectasia, but a normal ultrasound does not rule out IBD. Biopsies help identify lymphoplasmacytic inflammation, villus blunting, crypt changes, epithelial injury, lacteal dilation, and help differentiate IBD from intestinal lymphoma. In ambiguous cases, immunohistochemistry or PAR may be needed. Treatment is stepwise. First is a strict hydrolyzed or novel protein diet trial. Hydrolyzed diets reduce intact dietary antigens, decreasing immune stimulation. Correct hypocobalamin with oral or injectable B12. If signs persist, prednisone or prednisolone is commonly used. Glucocorticoids bind intracellular receptors, alter gene transcription, decrease cytokine production, suppress lymphocyte activation, and reduce mucosal inflammation. Budesonide is another glucocorticoid with high first-pass hepatic metabolism, so it may cause fewer systemic effects, although adverse effects can still occur. For severe or steroid-refractory cases, cyclosporine may be considered. Cyclosporine inhibits calcineurin, decreasing interleukin-2 transcription and suppressing T-cell activation. Antibiotics like metronidazole or tylosin are not automatic anymore because unnecessary use can worsen dysbiosis and contribute to resistance. Prevention is not absolute because genetics and immune regulation play major roles. The best strategy is early recognition of chronic GI signs, appropriate parasite control, avoiding unnecessary antibiotics, consistent nutrition, and monitoring predisposed breeds. For diagnosed dogs, relapse prevention depends on strict diet compliance, slow medication tapering, body weight monitoring, stool monitoring, and rechecking albumin and cobalamin. If you have topics you would like to suggest or donate to our video and game development, reach out to dogtoursgame@gmail.com.